seated on the far end of the stage so that you do not block the screen. And Dr. Gagan Prakash, you have 20 minutes. Thank you very much.
Yeah. Thank you. Good afternoon, almost good afternoon, everybody. As the panelists are coming in with the ticking clock, let me just start this presentation. So we have this topic called prehabilitation for urological cancer patients, which probably in the meetings that I know in India is being discussed for the first time. And there are reasons why it has been selected. I must admit that most of the slides and the concept and the thought that this should be discussed in Sogocon comes from this course from the AUA at Chicago, which was done recently, which was conducted by Dr. Sara and Dr. Viraj Master and Dr. Tuleka Garg. Personal experience is still evolving, but having gone through the literature, I'm glad that we are discussing this. And another disclaimer is normally I would prefer that when I'm moderating, I would give 90% of the time for the panelists to talk and probably 10% for myself. But I would not be able to stick to that because there are a lot of new things which I am understanding or we are probably will be understanding. So Dr. Vivekanand, consultant radiation oncologist from PD Induja is there. Kumar sir has graciously agreed. Vijay could not make it. And Dr. Sugdha is there from the Department of Anesthesia, with whom we'll be discussing this. So we all know about the concept of rehabilitation. We know about the concept of ERAS, and that's something which most surgeons have been practicing or at least knowing about for the last decade or so. But now the realization was why not use these techniques and things a step earlier. So right from the time of the diagnosis to the time you get the patient for initiation of treatment or say the surgery, let us optimize these patients, and this was the concept of prehabilitation. This is particularly relevant in our setting and in government settings where there's often a wait list for these patients to come from the diagnosis to the treatment. We've always focused at disease-related factors. So we've looked at scan and risk stratified, we've looked at the pathology and risk stratified, or even imaging. But why not look at the host factors? We are like a diverse, diversity within the country and within countries and within groups. So the whole idea was to focus on the host-related factors and tailor things about that. Now we have these conventional risk stratification tools, which all of us use in practice, like the age and the comorbidities and nutritional status and the ECOG and the ASAs. So Dr. Sugdha, we use this very commonly. Are you generally happy whereas, on a day-to-day practice, or you think there's something missing here?
Yeah, so as an anesthetist, I use ASA scoring, that is, American Society of Anesthesia scoring, physical status scoring, pre-operatively. I'm sure all my surgical colleagues are well aware of ASA status. Yeah. But within ASA scoring also, it is a very subjective score, and there are studies which show that between anesthetists also there is almost 25% of variability while grading the patients subjectively. For example, if a patient who is posted for say RCIC has undergone CABG surgery say 3 years ago, he falls under a category of ASA 3, which obviously everyone knows that ASA 3 means high risk surgery, high risk patient. But probably that patient is far healthier and fitter than a person who is, not having any hard, traditional risk from cardiac point of view, but, who is having a sedentary lifestyle, who is not working, who is not walking. So yeah, probably we need to modify and, reinvent our scoring.
Kumar sir, ECOG and the PS which we routinely use, do you find problems with it? Or you think it's good enough?
No, it is not, and that also depends upon the disease and also depends upon, for example, geriatric patients. We do know that ECOG PS is a good initial surrogate marker, but the moment you do for frailty test, you get a different kind of, the CARG score for chemotherapy toxicity, you get some different result, and also for frailty, you get a different result.
Right.
So yes, we are slowly learning that ECOG is the easiest way to do it, and I don't think so any parameter, this is something whoever did it long back has stood of the test of time everywhere. But again, now we understand there are many nuances which we all in the different field try to add on beyond ECOG.
I think that's what both Dr. Sukda and Dr. Kumar are trying to convey. I think the picture says it. The same gentleman with the very, my favorite, and I'm sure many of yours as well. But, you can see the difference over there. Vivek?
Can I add to that? So because you showed the geriatric population. So this is, we published recently from our geriatric clinic. 40% people had a different ECOG performance status, and when the geriatric evaluation was done for frailty, that was the difference what we had in the clinic from our geriatric clinic. So there's a good data for it.
Yeah, thank you. Vivek, please don't leak the information. And this is what Dr. Kumar was saying. So actually, when we looked at the discrepancies between the ECOG status, which was assessed by the physicians or the doctors, and by the patients, there was actually a huge discrepancy. And in fact, clinicians tended to overestimate the ECOG performance status. So what do we do in clinic? I mean, most of the times it's like a little eyeballing. We would assess the patient based on, our experience and our gray hair, try to say whether this is, this patient is fit enough to undergo the radiation or the chemo or the surgery. But there are issues over there, issues with specificity, with granularity, and with reproducibility. And the problem that arises is if you don't have a very granular way of kind of assessing the fitness, you might tend to overtreat a few patients, and you might tend to undertreat a few patients. So there is this concept of staging the host. For always we have been staging the disease, but now it's about personalizing the risk assessment of the patient, which is beyond age, performance status of comorbidities, and look at things which have been looked at, things like dependency, the severity of comorbidities, sarcopenia, malnutrition, cognitive frailty, and comprehensive geriatric assessment. Frailty, I think one of the most en vogue term that most surgeons or oncologists are using these days. Global manifestations of cancer-related inflammation, cachexia, sarcopenia, comorbidity, and malnutrition. So you can see that there's a plethora of factors which are actually acting to make somebody have a different degree of frailty. And a simple formula to understand this whole frailty in our minds is, say somebody's got a frail body and there's a stress of X, that gives you a negative outcome, not just surgical, but even in other treatments. And this X could be either cancer, it could be cancer surgery, or other cancer treatment. Now, I want you all to just have a look at this graph and understand what's happening. And I'm sure all of you would have already felt this with many of your patients, but now there is a little more objective way or a more granular way of expressing the same. I believe all three of my panelists would agree on the fact that if the patient with, say, the same ASA or even the same ECOG has been managing well, and then there's a stress, he would generally come back to the baseline. But if there's a patient who's frail, and if particularly severely frail, often they would not be able to come back to the baseline and end up with a dependency after the treatment has been done. And these are the set of patients that we would want to pick up or recognize before they undergo the treatment. Now, from all the three panelists, would you be using any of these frailty indices? There are like various scores and scoring systems. Sir, is there anything that has already become your favorite that you find it easy to use in the practice?
So we do run a geriatric clinic where we do the whole geriatric assessment, but it takes around an hour and more.
Right,
so
sir.
I don't think so that is practically possible for each patient. But good thing is that you do have a screening tools, and there are many of them. What it does appear that screening tool does help you in picking of those patients whom you want to do a more detailed evaluation. So that can be implemented in most of the OPD if people take it and you do have 8 parameter or 13 parameter in those scales, which can be done in 5-10 minutes. And that can be implemented, and especially for elderly people, and elderly 70 plus or 60 plus, that people can decide in India what should be the or 75 what should be the age to call geriatric population, because our median age is different from what is the median age for Western population, and this 70 has come from Western population. And by the way, Gagan, you will also be retiring at 60.
So,
NTMH, I am saying NTMH, not everywhere.
So, but then there is a
60, sir, for us.
yeah. And there is a comprehensive geriatric assessment, which now happens to be one of the most popular ones. And when we call it comprehensive, because it looks at the functional ability, it looks the comorbidities, it also sees at the mental health and the support which the patient has at home. And what we are trying to point out here is frailty and geriatric are two different things. So you could have a younger patient who's frail, and you could have an older patient who's doing good on a geriatric assessment. Now, this is something which I would want to check with Dr. Vivekanand, because I think you treat a lot of elderly prostate cancer patients. Have you felt the need to use something like this? Because you would have a fit 80 or you would have an unfit 70.
Yeah, Gagan, in prostate cancer patients, more than intake, it's the local problems. We'll have to assess what LUTS problems he has, or how is his constipation. Usually all these patients are constipated. So when we are treating the pelvis, we'll have to explain to them how it's going to be, because external beam therapy is not a big problem, and we should remember that most of the patients are above 70 and they are all rejects of surgery who come to radiation. So these people are quite unfit and they are old and they are apprehensive. So you need to talk to them that there is going to be a problem of further worsening of urinary bother, what we say, because of radiation. The bladder neck is going to be inflamed and it's going to take a long time to heal. And if the rectum is coming into the treatment field, definitely they have a higher incidence of proctitis and rectal inflammation. So these are the things I would look up, and added to that, we are going to use a lot of hormones. When we use hormones, I definitely tell them that it's very important to be active, fit. Most of the time I tell them to join a gym and be active. So that itself reduces. I'll give you one example. A guy about 68-year-old, he had come to just for radiation. He said, I don't want any brachytherapy, I want external beam therapy. After that, he became a marathon runner. He didn't have any symptoms at all. But if a person is not active in his usual routine life, he is going to have a lot of problems, because these things, it'll eat them into their own problems. It'll keep coming. So we'll have to talk to them and tell them they have to be active. This is the most important thing in especially pelvis and prostate cancer.
Right. So, Sir did mention that it's kind of really difficult. We are fortunate to have a geriatric assessment which is run by two senior medical oncologists over here, Dr. Vanita and Dr. Anand sees that. And as Sir mentioned, that it's a dedicated team effort, and there's so many realizations, I think, once that clinic could have started. But there are some simpler tests also. So, things like a 30-second chair stand, which has been described, you could see the details of it, or a sit to stand time, which has been defined. And these are things which you could probably do in the clinic, even if you don't have a geriatric assessment. The whole thing is that some kind of an assessment about their ability to exercise and how fit they are, some kind of an objective assessment should be done. As I mentioned, so now with this assessment, we come to, once we've assessed that somebody is not really fit or frail or has poor scores on the geriatric scale, that's what gets us to the prehabilitation, which looks at physical, mental, and nutritional status. And if you had to Google, what is happening to the prehabilitation studies which have been published, this is what is happening. So you can see in the last decades, there's suddenly a rise in the number of studies which are focused at prehabilitation. So we are looking at, involvement of the physiotherapist, optimizing of the comorbidities, looking at medications and the interactions of the medications, some dangerous interactions. We are looking at nutritional assessment and referrals. We are looking at psychiatry reference, often missed. And we are looking at specific things like dementia or cognitive dysfunctions, and whether they have a social support or no. And this whole concept is hugely pushed by various cancer societies across the world. So the American Cancer Society, called the ACS, actually has a program called Strong for Surgery. And Strong for Surgery is essentially, as you can see over here, looking at pre-op and immediate pre-op period with a program called Strong for Surgeries. Again, for nutrition, optimizing of blood sugars, smoking, and medications. Whereas in the UK, at the Imperial, it's an easy to remember mnemonic, and probably the carry home message from this presentation: prepare. So physical activity, respiratory exercise, eat well, psychological well-being, ask about the medications, remove bad habits, and of course enhance recovery, which is always already there. Nutrition. So again, a very, very important part is the nutrition. I think a dedicated nutritionist is probably needed to assess a lot of things at home. But there are these specific various brands are available in the pharmacies as well as nutraceuticals, the immunonutrition kind of things. So, sir, is this something that you would prescribe, or do you believe in, and do you think that's going to have a role, or only in people whom you feel is nutritionally not doing well? The supplements.
So not exactly these specific nutrition, not these one exactly. But I said there are many very simple things. What something we call you showed a part of it, and like potentially inappropriate medication. You will be surprised. Half our elderly people get potentially inappropriate medication. And these are some tramadol. We forget that it increases fall. You have to just take a bit of a history from the patients that in last 1 month, how many times you had a fall. And then you will be very concerned. But other flip side is that if you give other NSAIDs, then the kidney is a problem. So you become a bit careful when you're prescribing things at 70. You do have we have assessment for caregiver support, but as a caregiver, what kind of support the patient has. We do have a good, in Indian context it is good, but again, 1/3 of the patient we don't have a good caregiver which is available for them. So nutrition, sure, one can have some fancy nutrition, but some general good ones, what kind of protein or carbohydrate they are going to take. Many times they do miss that part. So there are some simple interventions which can be very useful in these patients.
Yeah. So I think...
can it still a surprising fact? Most of them, they don't use glasses. When these are the patients what we get in TMH, I'm talking about TMH patients, and I don't know how do they manage. And then say when you check their eyesight